Thank you so much, everyone, on the call today. I know it's good morning to some of us, it's good afternoon to most of us, and good evening to some of us. You're most welcome on this Zoom meeting today. And we're here with other 4 panelists who are going to help us answer the questions around HIV cure. I know that whenever I talk about HIV cure, so many questions arise from our own peers, so many questions arise from not only the community people, but even people that are already in the health field. And this is a very good platform. No PowerPoint presentation, it's a discussion where you're going to ask any question that you have around HIV cure, and I'm very sure that our panelists will be able to answer your questions. So with me, I'll start with Dr. Brad. So Dr. Brad is an assistant professor of immunology in medicine, and he's a co-PI, principal investigator in the upcoming REACH collaboratory. So we are going to have an opportunity of hearing more about that program called the REACH. And he's not just alone, he's also on with his colleague that is based in Uganda, Dr. Damali Nakanjago from Makerere University. The other two are Dr. Marina, and her work focuses on the development and clinical evaluation of the novel immunotherapeutic strategies against infectious diseases. And in here, her main focus is HIV and AIDS. And lastly, on the panel, we have Dr. Thumbi, who is a deputy director and a research group leader of the African Health Research Institute in South Africa. So we have a mixture of panelists from different fields, but all working and prioritizing HIV and AIDS. All the panelists, you're most welcome. So I'll start with Dr. Brad. When we hear about HIV cure, there are so many questions that come within our minds from our peers, from our fellow health workers at the health facility. So I would love to understand from a research perspective, what does an HIV cure world mean to you? What should we understand? What should we think about when we say HIV cure? Thank you.
Yeah, that's a great question. Thanks, Josephine. And good morning, everyone. Appreciate the chance to join this call. So I think you can define cure a few different ways, but to me, what it means is the ability to be free from having to take daily medication. So one would not have to take medication to suppress HIV anymore. And the reason would be that we have done something to either boost the immune system or to eliminate the small amount of virus that's left in people so that the virus stays under control without the need for ongoing medication. And it would be very important in that scenario that the amount of virus is zero or is so low that that person's health is maintains itself, and there's also no risk of passing HIV on to partners. So a cure would be, again, freedom from medication, freedom from the stigma that comes with being infected, and kind of medically that would be defined as either completely eliminating HIV or getting it to such a low level that the immune system can control it.
Thank you so much, Brad, for that. Indeed, as you have mentioned, it would involve freedom from medication. And as we all know, we've come from a world where people are taking very many pills. Currently, I only take 1 pill a day, and I hear developments around taking probably 1 pill a month or 1 pill in 3 months. Brad, does that mean that we are moving closer to an HIV cure?
Yes, I'd say that is moving closer. Having long-acting antiretrovirals, the lower the burden we have, the better. But I think when we consider a classical cure, the idea would be freedom of medication for the rest of one's life. So the ability to live a healthy life without any kind of ongoing medication is what I would define as a cure for HIV.
Thank you so much. I'll ask this to Dr. Thumbi from South Africa. And I'm asking you this because you're African, and there are so many myths and misconceptions we get around an HIV cure, where we think that some people are being cured outside Africa. So would love to hear from you, Dr. Thumbi. Is there a cure currently in the world? Is um is there a cure for us, Africans, or for anyone else in the world?
Thank you very much for that great question, and thank you for having me on this in this discussion. It's very inspiring. No, there is no cure. There's no standard cure for anybody anywhere in the world. There is no medication at the moment that anyone can take that would cure them of HIV. And that's not just here in Africa, but that's also everywhere else in the world. There have been a few cases in research studies where people have been cured. We know of 2 people that have been cured of HIV. We are familiar. Some of you may be familiar with the Berlin patient, as well as more recently the London patient, who have been cured completely of HIV, and HIV was not detected in their bodies. But these 2 individuals got cured under very what I would call experimental conditions. They were in both cases, in fact, they were suffering from some cancerous condition. They were HIV infected on antiretroviral therapy, and then they developed a cancer. And as a result, they underwent what we call a bone marrow transplant, which is a very complicated procedure. But as a result of that transplant, they were then able to durably control HIV without antiretroviral therapy. And it appears from all the studies done in these 2 individuals that they eliminated HIV from the body. But the truth of the matter is that other than those 2 people, we don't have any medication or standard therapy or intervention that anyone can take that would control HIV without antiretroviral therapy. So at the moment, we don't have a cure, but we are moving towards a cure. It certainly has been shown now from those studies that under some circumstances, it may be possible to achieve a cure, but we don't know the exact pathway that can get us to that cure. And that's why we are doing research throughout the world to see whether we can develop a cure strategy that could be applicable and to everybody, and also in a predictable way.
Thank you so much, Dr. Thumbi, and giving us that detailed explanation. We've had different viruses come, and a cure is gotten or a vaccine is gotten immediately, and we are just wondering, what is it? What makes HIV different from the others? Why is it so challenging for us to get a cure or a vaccine up to this time? We've had HIV for like more than 30 years, and we are still having discussions around an HIV cure. Why is it like that? This can be answered by any of the panelists.
I mean, I can attempt it, and then I'm sure my colleagues will also have a lot of things to add. From my perspective, I think the major challenge with an HIV vaccine is actually scientific, rather than the lack of funding or other issues. I think the problem with HIV is that it's such a very complex virus. The virus mutates and mutates very rapidly, much more than, for example, with a virus like the coronavirus, SARS-CoV-2, the one that causes COVID. So HIV mutates much more rapidly, and when it mutates, it's able to evade immune responses. so this makes it very different from coronavirus, and also it has regions. The regions of the coronavirus that don't change are very many, and therefore it's much easier for the immune system to target those conserved regions in the coronavirus virus, for example. Whereas HIV changes very often and in many places, and therefore it has become much more difficult to make a vaccine or even immunotherapy against HIV compared to some of these other viruses like the coronavirus. So I think it's mainly a scientific problem. You could also argue that there has been much more rapid global collaboration to develop a vaccine, the vaccine for the coronavirus. But I do think that the main challenge with HIV has been scientific, and until we get around those scientific problems and challenges, I think it will be difficult to develop an effective vaccine or a cure for that matter.
Thank you so much, Dr. Tumbi. Anyone else from the panel to add a voice to it?
Yeah, so I think Dr. Tumbi really hit on the most important point in terms of trying to make a vaccine. The fact that the virus just changes so quickly, it's a moving target that we're trying to hit. And then I would just add that when it comes to trying to cure infection, the other challenge that we have with HIV is that since it's what we call a retrovirus, it takes its genetic material, its RNA in this case, and then turns it into DNA, and then inserts that into our own DNA, so our own genomes, just in a few cells. It's not all of our cells that have HIV in it. But the problem is that once that HIV genetic material is inserted into our DNA, then it's with that cell for the rest of that cell's life. And that's different from something like a coronavirus, which has genetic material which is not as long lasting. So that's the other issue. So then the virus in those cells can go into what we call a latent state. So it still has the genetic material there. It still has the information, the genetic information that it needs to make a virus, but it can hide from the immune system for a long time, for years. So I think that is kind of the main barrier for cure, and also the genetic variability and the ability to change is also an issue for cure as well. From Jessica, can we explain what latent means? So yeah, I mean, I guess one way to understand it is it's as if the virus is asleep. So HIV can infect a cell, and then normally when it's in that cell, it's making more copies of itself. But sometimes it can go latent, by which we mean it essentially goes to sleep and stops making any new viruses. And when it's in that latent or sleeping state and not making any new viruses, it's very hard for the immune system to see it as well. And so that's why we think in some cases, if we want to cure infection, we have to wake up that virus. We call reactivate the latent reservoir. And that we hope will give us an opportunity to then kill those, just those cells that have HIV inside.
Thank you so much, Brad, for that. I'll ask everyone on the meeting to please have the microphones muted. And I'll request Jessica to probably mute those that are not muted. Thank you. So from this discussion, we brought up a point of the immunity failing to attack or target HIV because of its changing nature. And I'm just wondering, Dr. Marina, is it okay if you talk to us about the broadly neutralizing antibodies and how we can use this to actually target the virus? Because from Brad and Tumbi, we understand that the biggest challenge around it has been that it's been changing, and because of its changing character, we've not been able to find something to target it. So how can we use the blood deneutralizing antibodies to actually target HIV? Thank you, Dr. Marin.
Yes. Thanks for having me, for allowing me to participate today. So so Tumbi and Brett explained how one of the big challenges both to develop vaccines but also to cure HIV is how variable the virus is, and how unlike coronavirus, there are very small areas within HIV that don't change itself very rapidly. And in these areas, not only they are few, they're also hidden under a very thick and complex sugar coat over the virus. But what's interesting is in a percent, a subset of people living with HIV, over time, over several years after they have the virus, and then their bodies are in this constant interaction between the immune system and then the virus, they go on to develop these antibodies that we call broadly neutralizing. So these are special antibodies in the sense that they are able to recognize these hidden conserved areas of the virus, such that if you take those antibodies and then you try to see if they can block different kinds of HIV, they can find these vulnerable places within the virus to bind to that and then prevent the virus from infecting a new cell. So these are interesting molecules, interesting antibodies that a subset of individuals were able to produce in their own bodies. So the BNAbs, the broadly neutralizing antibodies that we have been testing in clinical trials, these were antibodies that were found in people living with HIV, that they were pulled out from their bodies, from their B cells. B cells are the cells of the immune system that produce antibodies. And they're remade in the laboratory into monoclonal antibodies, meaning that you create them again in the laboratory in a large quantity in such a way that you can then go on and then give these antibodies to someone else. And because they can recognize many different kinds of HIV, they have this possibility of blocking or keeping HIV in check, just like antiretroviral medications can, where the virus can remain within the cell. When the virus tries to replicate, it can be then cleared by the antibodies. And because the antibodies are part of the immune system, they can also have what we call a vaccinal effect, which is they're not really a vaccine, but they can tag the cells that have the virus. They can, if a cell that has a virus starts to produce that virus, and then the pieces of the virus are on the surface of the cell, these antibodies can detect these infected cells, bind to them, and then signal to the rest of the immune system, to the other cells of the immune system, that that's an infected cell that should be cleared, that should be killed. So several studies were done in animal models in the laboratory, and then show that these antibodies could actually prevent infection from taking place, or could suppress the virus to very low levels, even in the absence of antiretrovirus. So over the last several years, there have been several studies, several small studies with antibodies in people living with HIV that again showed that yes, combinations of these antibodies that target the virus in different angles can indeed maintain the virus suppressed, meaning that the viral loads can be maintained at undetectable levels in the blood, even if the person is to discontinue their own antiretroviral medications. So now the antibodies are being tested in different situations, either on their own or in combination with other molecules and other medications or vaccines that modify how the immune system sees the virus. These are all still very early studies, but because of what has been shown so far, we are hopeful that these antibodies may get us closer to an HIV cure, closer to a way of keeping the virus suppressed without needing daily medication. And then also teach us more of this interaction between the virus and our own immune system. So I think that in the next 2 years or so, when a lot of these studies start yielding results, we're going to understand a lot more about what the antibodies can and cannot do.
Thank you so much, Dr. Marina. And talking about the antibodies, being a woman on the call, I want to also pin this question to you. We've been hearing via internet that there was a lady that was cured in California without any treatment. And I would love to know, how is that possible? Is it true? And also, how can we learn from that so that probably we can expand it to other people that are living with HIV?
I don't know if I can comment in great detail about that. I think we don't yet know enough to know if this is yet another case of cure, like the Berlin patient and the London patient. Maybe Brad and Toby have more specifics to say about that. But I think in general, when we think about women in HIV and women participating in clinical trials, we know that the burden of HIV is really great among women, particularly young women, and the participation of women in studies, it's still a lot lower than men. And not only it's important for women to be able to have access to research and to be supported through their participating in research because they carry a lot of the burden of the epidemic, but also because we believe that there are differences between women and men in terms of how the reservoir, this pool of cells that still carry and hide the virus, that there seems to be differences between men and women. So therefore, maybe the different types of treatments or cure strategies would be required for women, and that would be different for men. So I think as a community, we all are interested in being able to explain the importance of participating in trials and the importance for women, and understanding complexities of day-to-day life of women that caring for their own kids. How to facilitate for them to be able to participate in these studies that in many ways are very complex, require multiple visits, that have to be coordinated with childcare. So because there's a lot to be better understood with HIV in women. But I don't know if Brad and Tubi would like to comment more specifically about the person in California.
Yeah, any other person on the panel to raise a voice on the lady from California that says has been cured without treatment?
And I would just maybe, this is Jessica, just to step in and say that this headline in particular is talking about what people call elite controllers. So maybe not just to talk about that, Laureen, but maybe also to say, what is an elite controller? Or somebody who controls virus, yes.
I think it's very important that we distinguish these terms, actually, as Jess, you are alluding to. There are different phenomena when people get infected with HIV. I think we are all familiar with that. When somebody is living with HIV, if they are not on antiretroviral therapy, for the vast majority of people, they progress to what we call AIDS, and they develop AIDS within about 5 to 10 years, approximately. But there are people who are able to live with HIV for a very long time, and they have a normal immune system, and their viral load is almost undetectable, or sometimes undetectable, and they are not on an antiretroviral therapy. So those kinds of people that are able to naturally control HIV without antiretroviral therapy are called elite controllers. So somehow those people have a very good immune system, and we don't always understand what it is about the immune system. And there is a lot of studies that have been done on these people to try and understand. So we understand some of the mechanisms, but we don't fully understand the mechanisms. And so those people are able to control HIV without antiretroviral therapy. Now, it's very important that we understand that it does not mean that those people are cured of HIV. It just means that they are able to live with HIV without antiretroviral therapy. But actually, some studies have shown that some of those people, when they are followed over a very long period of time, maybe for about 20 years or more, some of them eventually end up progressing, and the viral load comes back up. So those people are not cured of HIV. And sometimes those elite controllers are confused, or people are confused about those elite controllers. Those people are not cured of HIV. Now, there is also another group of people who, if they start antiretroviral therapy, particularly very early after infection, and then they interrupt for whatever reason therapy after some time. Let's say somebody got infected with HIV 2 months ago, and they start antiretroviral treatment, and then after about, let's say, 5 years, they decide for some reason or another they will stop taking antiretroviral therapy. There is a small subset of those people that go on to become what we call post-treatment controllers. In other words, they are able to live without antiretroviral medication and without the virus coming back for even for years. So that has been documented. But again, it is very important that we emphasize that those people actually are not cured, have not yet been cured of HIV. In fact, what happens is that some of those people eventually, the virus comes back and then the immune system deteriorates again. So those people are not cured of HIV. So, but what we are talking about is, can we actually develop an intervention? When you talk about HIV cure, what we are talking about is, can we develop an intervention that will allow people to completely come off antiretroviral therapy, and yet the virus does not come back? So that's a challenge. That's a scientific challenge that we are trying to solve. And at the moment, we don't have a solution for that. The fact that we have elite controllers who are able to control without antiretroviral medication, and the fact that we have so-called post-treatment controllers who can live even for years without antiretroviral medication after they have interrupted treatment, suggests to us that it is possible that for us to cure HIV and for people to live without antiretroviral medication. But because we don't know what it is that is causing those people to live without antiretroviral medication, it is very difficult. It has been very difficult to develop an intervention to mimic or replicate what is happening in those people. And that's why we are doing all these kinds of different studies to try and understand what is it about post-treatment controllers and about elite controllers, because that can lead us to an HIV cure eventually.
Wow. Thank you so much for that detailed and simplified, clarification on the elite controllers and the post-treatment controllers. I would love to know from you, Doctor, can someone tell that the elite controllers?
Yes, you can tell. You can't tell obviously just by yourself. You need to do some tests, because just because you are feeling well and you're not taking antiretroviral medication doesn't mean that you are an elite controller. There needs to be certain tests done that will show that your virus is completely suppressed and that your immune system, which is indicated by CD4 cell counts, that your CD4 counts are high and that your viral load is undetectable. So just because somebody is living with HIV and staying at home and not taking antiretroviral medication and is feeling okay, doesn't mean that they are an elite controller. In order for somebody to be classified as an elite controller, you need to do certain tests to make sure that the virus is undetectable and that the immune system is intact. Only then can that person be classified as an elite controller. And even elite controllers need medical care, because as I mentioned, some elite controllers who are not on antiretroviral therapy, eventually they lose control of the virus and their viral load begins to go up. So if they're not being monitored, it can be quite a dangerous situation. So this needs to be very, very carefully managed by a healthcare provider before nobody should just consider themselves an elite controller, without a proper evaluation by a qualified medical doctor. And the same thing with the post-treatment controllers. Nobody should interrupt antiretroviral treatment to see whether they will become a post-treatment controller. Because, as I said, the people who become post-treatment controllers are very, very few. And therefore, it will be quite dangerous for somebody to just interrupt treatment. This needs to be done only in clinical studies where there is a very close observation by qualified clinical professionals to make sure that the health of the person does not deteriorate.
Wow, thank you so much. Talking about viral load suppression, someone asked a question in the chat. They wanted to find out what are the factors that are hindering viral suppression, especially in Africa. Is there something different that hinders viral load suppression? Someone could be taking medication very well, but all the time viral load is done, the copies are very high. So I would love to know, are there certain factors apart from materials that really affect viral suppression? Anyone on the panel can probably come in and answer this, or Dr. Thumbi can continue.
Okay, again, I can just briefly comment, but I'm sure others as well might have some comments on that. I think if somebody is taking so first of all, we have to say that antiretroviral medication is the most important scientific innovation over the last 30 years, in my view, because it has enabled a lot of people to live with HIV and be healthy. So, but of course, antiretroviral medication can fail because of the emergence of drug resistance. But drug resistance variants of HIV usually emerge if somebody is not adhering religiously to medication. So if somebody is keeping pills here and there, then resistance and resistant viruses can begin to crop up. The only other reason I can think of is that in some cases, somebody may have particular what we call co-infections, certain co-infections, such as malaria and so on. And sometimes they may be taking medication that may interfere with the antiretroviral medication that one is taking. In that case, then you may get spikes of the virus going up. So again, this is why it is very important that antiretroviral medication should be overseen by a qualified medical doctor so that they can prescribe and they will be able to know whether there is drug interactions that might interfere with the effectiveness of ARVs. But also, it's also very important that if somebody has co-infections, such as malaria or even other, co-infections, that they are treated properly for those co-infections, because all of those could be things that could lead to certainly even transient increases in viremia, in viral load, which is not a good thing. Maybe Marina and Brad might also have additional comments on this.
Yeah, Marina or Brad, anyone?
I think so. One comment that I would make that is maybe linked to this is that when someone is on ART and the viral load is undetectable, it's fully undetectable. we know that there is a decrease in ongoing inflammation, which is another problem that one can have with HIV. The one part that we are still not clear, and we have to understand more when we are thinking about cure strategies, is how low do we have to suppress the virus without medication to both prevent transmission to a partner, but also to decrease this ongoing inflammation that can have with HIV. And it's something that I think is very important for us to keep in mind, both when we are thinking about managing HIV with for example, these broadly neutralizing antibodies, but also when we look at individuals that discontinue ART and then they become what's called the post-treatment controllers, that might have still a low level of virus that is not fully suppressed. It's low enough that there isn't quite a concern about transmission, but will the health of that individual be quite the same without treatment, but with this low lingering amount of virus circulating in the blood as someone who is on ART long term? So this is a side piece that we have to keep in mind. Should we be so successful to achieve this type of control that is not complete control, complete elimination of HIV, but we have to not lose sight of that.
And
All
just
right.
maybe to interject quickly,
Yes,
just Marina, while you're there, there's been a couple of questions about broadly neutralizing antibodies and maybe if there are gender differences and what potential impact hormonal treatment might have. And I wonder maybe if since you're on the floor, if you could just talk a little bit about maybe sex and any impact on BNAPs.
So I don't think there are reasons. So the answer is we don't know if there are differences in how women or men would respond to different antibodies, but I don't think that there is any scientific reason known to us to expect that there would be differences in how they would, how good the antibodies would be in suppressing the virus. And as far as how the antibodies would interact with hormonal therapy, again, I don't believe, so we all have antibodies. Our bodies, we have lots of antibodies against many different things that we have been exposed to over our lifetime. And being on hormonal therapy, there isn't, again, a reason to think that being on hormonal therapy would lead to faster clearance of antibodies that we give to somebody to suppress the virus. But obviously, studies that involve people with HIV that are on hormonal therapy, there have been in small numbers of individuals that specifically like that participated, but not enough for us to know for sure. But again, like I said, I don't think there is any reason to think that the hormones would interfere with the antibodies, both in how long the antibody effect would last and in the effects themselves.
Okay, thank you, Marina, and thank you, Jessica, for pepping in. I see in the chat we are really having a very good conversation, and I would love to understand, this is HIV cure research in Africa, because I see the minutes are going, but we need to understand, are there any cure strategies that are being researched on? If they're there, what are they? And particularly, do we have any cure strategy being researched on in Africa? Because when you look at the burden of HIV, Sub-Saharan Africa comes first. So we'd love to know, is there any particular study around HIV cure in Africa? Anyone on the panel can help me answer that.
Yeah, I can answer certainly about our study that is planned. So we are planning a study in Durban, South Africa, where we have a cohort of women called the FRESH study. In the FRESH study, what we do is that we identify women with very early HIV infection. And we are able to do this because we test them twice a week for HIV infection using RNA testing. So we know as soon as somebody gets infected, we are able to to identify them. And then we start treating them with antiretroviral therapy immediately. And we hope that that helps us to reduce the size of the viral reservoir, but it also helps us to keep, we have been talking about this problem of HIV, of diversification of HIV. So when you treat people immediately, you also reduce the ability of the virus to diversify, because the reason the virus becomes diverse and the reason it develops so many variants, because it is constantly replicating. And also, actually, when you treat people early, you preserve some aspects of the immune system. So because of this, of all those benefits of early antiretroviral treatment, once we treat them for about 1 year or 2 years, we are then thinking that maybe we can begin to intervene with a broadly neutralizing antibody, actually a combination of broadly neutralizing antibodies, as well as agents, biopharmaceutical agents that can reverse latency. And then after we give the treatment, we will interrupt treatment, and then we monitor to see whether the virus will come back, and also to see how long it will take for the virus to come back. So that's a study that we are hoping to start the study later this year, if everything goes well. The study has been approved by the ethics committee, and the study has also been approved by the South African Health Products Regulatory Authority, SAPRA, which is a regulatory authority in South Africa that oversees clinical trials. And so we are hoping to start this study later this year. Just also to comment that there are other, of course, there are other strategies for, other than using these immunological agents, there are certain other strategies like gene therapy that actually have been tried and are being investigated, particularly in Europe and in the US. And we are hoping that these kinds of strategies will also be attempted here in Africa in the future. Although, not as far as I know, none of them has been attempted here in Africa at the moment.
And
Okay,
maybe
thank you.
yeah, maybe I can just add to that as well. So one of the studies that that I'm doing along with my colleagues Marina and Jessica and Damily is to develop the different ways we have of measuring the HIV that persists in people on therapy, the small amount of HIV that we call the viral reservoir. There's ways that we can measure that right now only work for subtype B HIV, which is the subtype that's present in North America. And so there's some research and some development that's needed to be able to take those important ways of measuring the virus and apply them to the different subtypes of HIV that are present in Africa, such as subtype C. And so that is not pure research just yet, but the work that we're doing on that, we think is going to make it a lot more possible to do cutting edge cure type studies in Africa. So we think that's an important first step that needs to be taken urgently.
Thank you, Brad. Dr. Tumbi, you talked about early treatment, which, and from all the explanations that we have, will have a great contribution to the size of the reservoir. And for the benefit of the entire audience, a reservoir could be defined as an HIV hiding place. So these are places where HIV is hiding, but the current ARVs cannot reach those places. So I would like to ask, when we talk of early treatment, you're looking at women in the study, but what are we doing for the children that are still being born HIV positive? Have we thought of early treatment for them? And if we have thought about it, what is really early treatment? Is it a day after infection? Is it 2 days? Like, what is early treatment? I would love to know the exact time frame around that.
Okay, another excellent question. Actually, one of the areas of very active research also is to explore HIV cure strategies for children. And again, here in Durban, we have a study that is ongoing where we identify children that are born with HIV from HIV-infected mothers. So we identify them within 24 hours of being born, and then we put them on treatment immediately. And again, the idea is that we might be able to intervene with some of these cure strategies like broadly neutralizing antibodies and vaccines, a combination of different immunological modulators in order to see whether we can achieve an HIV cure. And there are some studies again that have been done, including one study here in South Africa, where a child was followed from birth and they received very early treatment. And this particular child seems like they were, once antiretroviral therapy was interrupted, the virus did not come back. So there are these anecdotal cases where some children have been treated very, very early, within a few hours of being born, after they were confirmed to be HIV infected. And then when therapy was interrupted, again, the virus did not rebound. The problem with these studies is that nobody understands for sure what it is that happened in those children, or because for the vast majority of children, if you interrupt treatment, the virus will come back. So we don't know what it is about these few cases where they are able to control by themselves. But again, these studies are now being done, and we hope that we can understand more about the mechanisms that, because if we do, then that will enable us to replicate this in other children.
Okay, thank you. Any other addition from the other panelists? Okay, so if there is none, we are in a situation where we had the healthy threat, which is COVID-19. And we are now talking about HIV cure research, that is, happening in other areas, and also are planning to start happening in other areas. And we are wondering, is there an effect? Are there effects that have been, created by the current situation of COVID-19 to HIV cure research? Maybe Brad or Marina or Damali can go first, so that Dr. Fubi can rest a bit.
So, sorry, I was typing. I
Yes,
missed the question. I don't know if someone else can.
So sorry. I know I see the chat, and then I'll thank you so much for those that are engaging on the chats, and for all the panelists that are engaging both here and also on the chats in the chat box. So I would love to know, are there effects that you're going to receive in the HIV cure field as a result of the current pandemic of COVID-19?
Are there effects? Are there positive effects? Are there lessons that we learned from COVID-19 that we can apply to HIV? Is that the question?
Yes, it could be that. Like, what has the pandemic caused as probably positive effects or negative effects to the HIV cure field?
Yeah, I mean, I think a bit of both. I mean, one thing I can say first off is that the response to COVID-19 benefited a lot from the research that has been done in trying to find vaccines and cures for HIV, and not only for the scientific knowledge, but from the networks of investigators and the skill sets that people had. The response that exists to HIV really helped to launch, in many ways, the response to COVID-19. In terms of the impact of COVID-19 research on HIV, yeah, I think there has been a bit of both in terms of negative and positive impacts. Certainly a lot of, there's been downtime in labs where we can't physically be in the lab to some extent, or clinical trials have to be put on hold, or people who would come for study visits to give samples have had to postpone those. So I think that there has been, just in a practical sense, disruption to HIV research, not completely, but to some extent, but that at least in places that have access to the vaccine is changing. So our labs here are fully open again at the moment. In terms of positive benefits, I think, yeah, I'd be certainly interested also to hear Marina's take on this. But even though the HIV field has been collaborative and has been working very hard on advancing a cure or a vaccine for HIV, I think it's fair to say that the level of global collaboration and the level of energy and resources that have gone into the COVID response is something that we might aspire to also in the context of HIV. I think there was some really great examples of people working together and working urgently and achieving really amazing results. So I think that's one thing we can take. I'm trying to think on the scientific front, are there specific lessons we can learn from COVID-19? Having a bit of a harder time coming up with, with a specific example there. So maybe I'll pause there and pass to my colleagues to respond as well.
Okay, anyone else?
Yeah, so I think on the scientific side, I actually think that the COVID research world learned quite a lot from HIV. So you know, this when we have panels like this, the question of how can it be that we have a COVID vaccine so quickly and then we still don't have an HIV vaccine, which is very true, and I think both Tumbi and Brad explained the many differences between the two viruses that make an HIV vaccine a lot more challenging to accomplish than a COVID vaccine. But I think it's important for us to recognize that the effort of all of us together working to understand HIV, to develop platforms of vaccine platforms for HIV, really enabled COVID vaccine research to happen so quickly. Because you know the technology behind the Pfizer vaccine, the Moderna vaccine, the AstraZeneca vaccines, these are all strategies that had been in place partly because they had been worked on for an HIV vaccine. So I think the HIV field has scientifically helped the SARS-CoV-2 vaccine field quite a bit. And in return, I feel like Brad says that COVID really taught us the power of collaboration. What we saw happen in the last year and a half in the amount of new knowledge that was generated by different groups that had not worked together before coming together and then releasing the results very early on really accelerated all of the process. And I hope to see that this now, it's something that remains in the scientific world where people will be more forthcoming and more open about their discoveries early on so that one can build on each other's work.
Okay, thank you, Marina. And yes.
No, so Josephine, there's just some really great questions that I hope that we get to in the chat. And I know we're almost at the top of the hour, but there was a great question from Mandisa about a particular study using a vaccinomide from Gilead. And I wonder if we can go over the strategies, just talk briefly about them and just maybe define what they are. And then another question, which is, you know, why do we measure HIV? We talk about it being in the blood. So how do we do sort of an oral, like what did the oral swabs tell us about HIV? And maybe just a little bit about like when we talk about the reservoir and we talk about virus, what are we actually measuring in both of those and how do we measure? So how do we measure and what are the strategies?
Thank you, Jessica. I'll ask everyone who is not in the panel to please mute yourself. Thank you. So I don't know whether Brad can explain to us, you know, some of the strategies and the other questions that Jessica.
Sure, I can start with the last question first. Just what are we measuring when we're measuring the HIV reservoir? That's a really good question. We don't know exactly what is the best thing to measure that would predict whether or not virus rebounds, because viral rebound, of course, is the main thing that we are trying to stop from happening. But a few of the things that we think will be good readouts are measuring the viral DNA, so the viral genetic material, because that tells us how many total cells are infected with HIV. But one thing that's complicated there is that most of those viral genomes, that viral DNA is defective. So they're missing pieces of the virus. And so those can never initiate viral rebound. They're just kind of distractions if we're trying to measure those actual intact proviruses. So that's where this new assay that's called the intact proviral DNA assay that we're adapting to the subtypes in Africa is an improvement that lets us focus in on just those viral genomes that have the potential to initiate viral rebound and viral spread. The other way that we can measure the reservoir is a co-culture assay. So we take CD4 T cells from the blood of people with HIV, and then we stimulate them in the test tube to reactivate the virus. And we can measure the frequency of cells that have virus that can replicate in those individuals. So that's harder to do. It requires more infrastructure to measure. But it's a little bit unclear which of those is really the best measure at this point. Regarding the vesatilimod, I'm not sure if I'm the best one on the call to comment on that. I can just say briefly, that's the TLR7 agonist. And so this stimulates part of the immune system, the innate immune system. And so there's two things that could do. It could modulate the overall immune response so that so it acts like an immunotherapy and boosts the immune response against HIV. It also might be one of these agents that wakes up the virus that is sleeping, that will allow the immune system to see this virus, so reactivate this latent virus. And the study that I'm most familiar with was the monkey study, the non-human primate study of this TLR7 agonist. And that was one of the first studies that really showed that following treatment with the TLR7 agonist, many of the monkeys were able to control their viral replication to undetectable levels without antiretroviral therapy. So based on that, Gilead took it forward into the human clinical trial. But I'm not sure, Marina or Thumbi, maybe you have more direct familiarity with that study than I do.
I think there have been a number of these studies now, actually, both in monkeys, but also in humans with vesatilimod, which is a toll-like receptor agonist. And as Brad says, it stimulates the immune system. In fact, this is the same drug that we are hoping to use here in South Africa in combination with the broadly neutralizing antibodies. And so the idea is that this drug, together with the broadly neutralizing antibodies, will have antiviral effects. Any virus that might come out of the reservoir will be killed because the immune system will be boosted by these broadly neutralizing antibodies, which, as Marina said, have direct antiviral activity, but also that these antibodies plus vesatilimod, this drug, will stimulate the innate arm of the immune system and even perhaps the adaptive arm of the immune system, which will enable the immune system to basically overwhelm the virus and hopefully lead to a durable control of viremia. So we don't know whether that's going to happen, but that's certain. Some studies have suggested that that's possible, at least in some participants. But now what we want to do is combine that with a broadly neutralizing antibody and see whether that will lead to long-term remission.
Okay, thank you, Dr. Tumbi. I know that we are a couple of minutes after 3, which was the agreed time to end the meeting, but I want to thank all the panelists. I want to thank Dr. Thumbi. I want to thank Brad. I want to thank Marina and Dr. Damali for being up on the call to not only answer these questions, but also participate in the chat where we've been having a very great discussion about questions from the participants. To all people that are on the call, thank you so much for being online. Thank you, Jessica, for organizing this. I want to let everyone know that as in Africa, we are still looking for a cure. There is no cure currently, but different strategies, different research studies are being, initiated and undergoing. So do not feel like probably other people are being cured. Do not feel like Africa is left behind. Something is being done, and I know that we will be able to get an HIV cure because our research is ongoing and it has benefited other healthy conditions, for example, COVID-19, which we all know, and from the discussions that we've had from the great panels. Thank you so much. I want to end this here. God bless you. And in case you have any questions, please feel free to reach out to our social media handles or through email. I know that Jessica can be able to connect you all to the panelists that have been on the call. Thank you so much. Bye-bye.
Thank you, everyone. And make sure you check out some other sessions in the zone this week.
Thank you.
Have a wonderful
Bye-bye.
day. Goodbye, all.
Thank you.
Bye.
Bye.
Bye.